staging is important because it provides some guidance to the clinician about therapy and provides prognostic data for the patient to know what to expect. So proper staging is important for us to plan the road ahead. And what happens is that if one of the, so in general, the way we stage patients, we use the TNMB staging criteria. So T is for skin burden of disease, B for blood burden of disease, N for nodal burden of disease, and M presence or absence of mesenchymal organ or internal organ involvement. So those 4 stages, knowing whether they are involved with the disease or not, are important for prognostic and therapeutic reasons. So a proper diagnosis early on will require evaluation of all those areas. That doesn't mean that we have to do a major workup with PET CT scans and bone marrow biopsies. I'm not saying that, but at least we need to look for signals of potential internal involvement by blood analysis, palpation of lymph nodes, and detection of any what we call B symptoms or constitutional symptoms. The workup of a patient with CTCL, it will vary depending on the clinical presentation. We often see new patients sent to us with a potential mycosis fungoides diagnosis, but it's not very clearly established. So so the diagnosis of CTCL can be tricky. And the same way that CTCL is often underdiagnosed, there are also many patients which are overdiagnosed. So the sensitivity and specificity of histological diagnosis is not 100%. And it's not 100%, again, because those cells are mature, because eczema can look like mycosis fungoides can look like eczema or psoriasis. So there's always a dilemma there. When we see a new patient, we may have to obtain multiple biopsies to be able to nail down the abnormal finding. We need to do immunohistochemistry and molecular studies on the tissue, looking for defining a clone in the skin and finding the same clone in the blood may be very important. This identity of abnormal clones is very important. So we do a full evaluation of the skin compartment. Obviously, we palpate for lymph nodes. If there is an abnormal signal with the lymph nodes, or there is serological evidence of potential blood systemic involvement, i.e. high lactose dehydrogenase markers or some cytopenias, or palpable adenopathy or constitutional symptoms, we then order PET CT scans. And if there is if there is an abnormal lymph node identified, the next step will be to obtain lymph node biopsy. Finally, we assess the blood assessment on all of our patients, whether they are stage 1 with very limited disease or are erythrodermic. So all patients with cutaneous T-cell lymphomas will undergo CBC with a synchronous flow cytometry. Why do you do them synchronous? Because flow cytometry provides percentages which need to be translated in absolute number of cells. So our patients, a small percentage, about 2-3% of patients with stage 1A with very limited skin disease may show already an abnormal signal in the blood that will need to be followed. So all of our patients will have CBC flow cytometry LDH, and a comprehensive chemical panel of the blood. All our patients will have a partial or complete analysis of lymph nodes, either by palpation or plus minus CT scans and or biopsy in case of an abnormal finding. And all of our patients may have multiple skin biopsies to fully identify the nature of the abnormal T cells. And that's pretty much our staging approach before we decide on a therapeutic area.